Welcome you to this press conference. So thank you for taking up your time. Director General of the National Public Institute of Liberia, Dr. Christian, we're a guest of Liberia, training the issues in our country. So we thank you for coming. We'll now turn the floor over to the Director General. We're getting Okay. Ladies and gentlemen of the press, good afternoon as well. As always, we are in an outbreak mode and situation, so we will have these conferences on an impromptu basis at some point, given the developments that may be obtaining in the public health ecosystem of our country, the region, and the world, as we all gear towards working together in order to ensure global health security. The Deputy for Technical Service is on my left, Dr. Gedeyene. The Deputy for Administration is next, Dr. Lincoln. And then we have a slew of other officials from the National Public Health Institute, directors and assistant directors and representatives of the various divisions. The first we will do is to update you on the Mpox situation that we have been handling since the 13th, 14th of August, when it was announced by the Africa CDC as a health situation of continental concern and security, and the WHO as well. But we have been responding to Mpox as an institution for the past couple of years. To date, since that announcement was made and the declaration was made by the Africa CDC and the WHO, we have now 26 active cases. To date, we have about 37 recovery. But in total, we have 63 confirmed cases as of today. These figures will be updated. Again, I know when we gather here, we exchange information on what these cases are, and we continue to repeat and reiterate the definitions. We are glad that no misinformation has come from the press since the early day when we had that one incident. That shows how cooperative we've been and how we've been able to learn from each other. So some of our public health medical jargons. So we must really appreciate and congratulate you. When we have a particular outbreak like Mpox, and we have all the symptoms that we say will tell you this person seems to have Mpox just by looking at them, physical symptoms and inward symptoms, and then we go toward diagnostics, whether through molecular biological means or through serological means, meaning there are different tests we can do to now detect and confirm. So you will have what we call a probable case, meaning that it's possible that this person has Mpox. Then we have a suspected case, meaning that we really think now this person has Mpox. Then we have active case, meaning that we have now determined that this person has all the symptoms, the fever, the blisters, those rashes all on the hands and the palms and on the body. But then we do laboratory tests to confirm it. So that person now becomes a confirmed case, and that confirmed case becomes an active case. And you have been learning those definitions very efficiently. We really appreciate that. We have not seen any mistake coming from the press. In recent times, you will note that we have had so many recoveries because of the way the National Public Health Institute, which has the National IMS case management pillar, has been able to improvise in the absence of enough materials, enough medications, etc. But I've been able to improvise so as to have people who are falling ill with Mpox getting well. So we want to thank all of the pillars, particularly those with the National Public Health Institute that have dedicated themselves to this response. When you compare us with the rest of the continent, the National Public Health Institute of Liberia has been doing pretty well. We have been receiving all of the appreciations from various bodies like the Africa CDC and the WHO country team and WHO Afro and the West Africa Health Organization that visited here recently in order to assess the Mpox response by the National Public Health Institute and the Ministry of Health. And so it all goes to say that you have played your part as well, particularly the risk communication that includes you, the press, that we've not had any misinformation because we've been able to properly address it and you've been able to accurately also report. We really appreciate that you've called us. Our numbers have been given to you and you call us if you have any questions. We are always willing to answer your questions. We are giving you impromptu interviews and whenever you request them, we arrange the time. So we will not stop re-emphasizing that because communication is very important in public health work. Not just that, but in every aspect of our work, be it in finance, in administration, just anywhere. But particularly for what we are dealing with, it's very important because one nomenclature that is mistaken can create a whole new havoc in a community, in a country, in a region, and in the world. And so we have to be very careful as professionals and as lay people. That is why when we provide you these briefings, we try to make them as simple as possible so that all of us can understand. I know some interviews that have been done by New Narratives and FPA and LNTV with Willietta and Gloria. We've gone to the extent of speaking very, as broken as we can, the English, so that the layman in the village, the laywoman in the village, Ma Hawa and Papa Flomo can understand what we are saying, and Uncle Toe. So we go to the Sunday school, so that I don't say I'm only talking about nothing else. So that's where we are with Mpox response. We do expect that vaccines will come in. The National Public Health Institute have repeatedly put in for vaccines with the request with the Africa CDC. What we gathered is that before we could have these properly arranged based on protocol, based on requirements that needed to be met, we were informed by the Africa CDC that there was a communication there requesting vaccines. That came from the Ministry of Health. These vaccines, let me come to that, are not the regular vaccines that are given in a clinic on a regular basis, like polio vaccines, like hepatitis vaccines that you go to get three doses for boosters. These are emergency use authorized vaccines. What does that mean? Under certain circumstances, when there's an outbreak, science have developed so much that now we are able to produce vaccines just in little over 6 months to a year. Why? Because the technology that we've developed in the past that we thought was not viable was brought to life when we had a COVID pandemic. That technology is called the mRNA technology in vaccine production. With the rapid speed and investment of the US government and the European government, companies like Pfizer, BioNTech, etc. were able to utilize this technology to produce mass of vaccines that were then given all over the world. So, but the studies that these vaccines undergo may not be as thorough as we will go through the regular clinical trials when we produce medications, pharmaceuticals, and then vaccines. They go through the rigorous clinical trial over years. It takes like 10 to 15 years before they can even bring the vaccine or that medication to the market. But nowadays, technology has advanced so much that we are expediting these things because of the way the pathogens, meaning those things that cause us the disease, those bacteria, viruses, etc., the way they are changing themselves as well, they are mutating. So, we are at that stage where even the MPhil currently, and we will get there, is on the path of acquiring some tools with some of our young scientists that we have here, including myself and our epidemiologist. We will be doing a lot of research that will lead us into research and development for vaccine production of major diseases that are affecting us. We'll be looking at Lassa, we'll be looking at COVID, we'll be looking at Ebola and malaria, among others. But we will do the best we can to at least confine ourselves in the initial stages with the technology so that we can become effective and efficient. So we will be doing that. The MPhil under our leadership will be doing that. We will also be researching and developing diagnostic tests as well. We have the technology, the technological know-how here at MPhil now and before. So we want to harness that energy, those brains, in order to be able to produce our own diagnostic tests and our own vaccines. That is going to be done in cooperation with others in the region. These efforts are collaborative. So we will be collaborating with institutes like Noguchi, institute like Pasteur, MRC, etc. But the fact that we now have those technologies gave us that edge now to cooperate, collaborate with others. Before, Africa as a whole was just sitting and waiting for vaccines and diagnostics. So these are the meetings that we have been having in these recent times in the DRC Congo, in South Africa, in Lomé, in Addis Ababa, etc., etc. That Africa now wants to take research and development out of the sky, let me put it that way, right on the African continent, and that will lead to manufacturing also. So it wouldn't be that we only produce these things, bring out the ideas, and then we send it outside for manufacturing. No, the manufacturing we want should be done on the African continent. So those are the steps that the Africa CDC, along with all of the national public health institutes, which are like the branches of the Africa CDC in the various countries, that's the path we are taking. We also want to emphasize in this regard, as we talk about technology, that again, we were able to acquire this sequencing capability. It's a very significant gain for our country through this entity, because you can talk about vaccines production, research. You can talk about diagnostics if you don't even know what you are looking at, what you are dealing with. So we did lack those capabilities before, but now we have that capability. I think it's a real good plus for our country, and thanks to all of the young scientists here and the team, the DRDE and diagnostic division that were able to capture that through the programs that we design here. And thanks to the Africa CDC and the WHO, as well as other entities like the US CDC, USAID, UNICEF, AFINET, and all of them, for their assistance in this regard. So we're able to now do that, through which we were able to determine that we have clade 2B here in Liberia. Now, we also know that we have clade 2A, so we are able to now know what we have. And these guys are at the National Reference Lab. They're just playing with this technology now. I mean, they're having fun. The next thing we want to do is, you see, these technologies are on different platforms. It's like a cell phone, but you have, somebody has Samsung, and you have, you have a BlackBerry, or you have, I use BlackBerry, I still do. Or you have iPhone, Disclaimer, I am not promoting any product here, but it's just to give a classic example. Now, you know that maybe the Samsung has what, 2 slots, right? Double SIM, right? iPhone, just, 1 SIM. So you have different capabilities, different opportunities. So we are going to train on the other platform for sequencing. That platform allows us to sequence genes that have what we call a lot of bases. It's like if one bacteria, let's put it that way, or virus is, I just want to give you a simple example in terms of height, is 4 feet high, and another bacteria is like 20 feet. So you can see the difference. Now, one machine will be able to do those little ones, and the other machine will be able to do the bigger ones. So those are the platforms. So we are going to learn on the next platform called the MySeq, and that gave us an ample capability to sequence more pathogens, viruses, bacteria, etc. So that's the direction we are going, and we really want to thank you for carrying this message out. So the map of sequencing on Africa used to be red. In 2016, 2017, we have only 4 or 5 grains, 5 countries. So any country that is added there, then they color a grain. In less than this time, can you imagine, like Enfield was not found at that time, right? But later on, 9 years after Enfield was founded, and after that time till now, Enfield has now placed Liberia on the map, and that area is now green. The lady presenting was joking and came up to me after I made a presentation at a conference that, oh, So my map is outdated. You say, yeah, it's outdated, you need to change it and color Liberia green. So these are the platforms that we are playing with. Once we get those two, we'll be very versatile. That brings me to the Lassa fever suspected case and confirmed case, that case which passed away in the US. We got the sequences from the US. What we intended to do was, now we have our sequencing capability, right? So we have now done sequencing of the most recent ones that we had from the region where that person who passed away visited, so that we are able to compare those sequences with the sequences that they took, the ones they took from that patient, and were able to analyze in the US. The file is so heavy that we are still finding means of sending it out to our colleagues. So if our US CDC colleagues are listening, we've completed the sequencing. We are now finding a way to have it sent to you because of the large file and limited internet strength here. So we're doing the best we can to have the file sent out. Excuse us as LEC is switching over now, so we are all aware of these kind of conditions. So that is it for the Lassa. So, still on Lassa here, as you know, we are also responding to multiple outbreaks. So it's not just Mpox that we are responding to. We are responding to Lassa, we are responding to measles, and a few other outbreaks that keep cropping up. To date, we have 39 positive for Lassa out of 231 suspected cases. So we have 231 suspected cases, right? These cases are only suspected. We think these people have it because of their symptoms and everything, which is evidence also. Then we go deep down into more evidence gathering to take the samples and then test them. So those tested ones are the confirmed ones, and those are 39 positive out of that whole 231. So we want to distinguish that. And out of that, we have 177 negative. Now, the interesting thing is, although this may be negative, they may be carrying something else. So there where the sequencing capability gives us that latitude, that ability to look at that sample again to see what else could be in there if, in fact, Lassa is not there. So then we have two of those samples that were indeterminate, meaning we couldn't tell whether it was Lassa, it possibly was, or it was not. There are test indications. It is those indications that we go back to say this is positive or this is negative. Now when it's confusing, it's giving us mixed signals, then we say it's indeterminate. That brings us to this indeterminate situation with the viral hemorrhagic fever that was reported as a suspected case in the Republic of Sierra Leone, our neighboring country. I believe most of you may have followed that on different platforms. Some were saying that it was just internet misinformation, but it was not. Here at the Enfield, this leadership have tried to establish good cooperation with the other Enfields in the region. So we cooperate and collaborate with the Ministry of Health / Enfield in Guinea, and then we also cooperate and collaborate with with the National Public Health Agency in Sierra Leone. Similarly with Africa Coast, just in the sub-region. Then outside of here, of course, Mali, Nigeria, Ghana, etc. So when these things happen, we are on the basis of public health transparency and accountability, we inform each other, particularly these three countries, knowing where we came from with Ebola, which is a viral hemorrhagic fever, one of those ones. Then Marburg, another one. So knowing where we came from with Ebola, we are very vigilant. Our surveillance system is very keen, and we test for those regularly. When I say regularly, we test for those regularly. That's the only way we will know if something has happened or not. Now we have the capability to do the testing. We are now doing it. So in Sierra Leone, almost like 4, 5, 6 weeks ago, in the Kono region, which is the eastern part of Sierra Leone and the western part of Liberia, just right in that region where our border is, they suspected that a healthcare worker has symptoms of a viral hemorrhagic fever. Okay? They only suspected. When they suspected that, the patient left the Kono region, went to Freetown, and by the time they did treatment and other things, that patient passed away. When the patient passed away, of course, they had taken some samples. They are not known. Then they took some samples. When they tested the samples, right? Remember back in the days, it took like 2 months for us to get the first Ebola sample back, the result, back to Liberia. Nowadays, since that time, we have all developed certain capabilities that we are able to do these tests now. So when they tested it at the 34 Military Hospital in Freetown, the result came out indeterminate. So here we are. They only suspected. Then the results came out indeterminate. So there was nothing confirmed. At that rate, nobody could say they detected this or they detected that. We have the same situations here sometimes where I just read to you 2 of the samples that were indeterminate. So we couldn't say whether it's Lassa or it's Lassa. And then we have to do other things. So this was the case with this viral hemorrhagic fever case, suspected case. Since it was indeterminate, the Sierra Leonean National Public Health Agency, thanks to Dr. Fodesa, who is the executive director there, our colleague, and the team, they were able to do their contact tracing immediately. And then they have almost like 291 plus contacts that were listed. They followed them for the 21-day period. They were isolated and then followed for a 21-day period to see in between that time if they would develop any symptoms. Because the thing can be hiding somewhere and later on it can start showing its ugly head. So during that time, we were in constant communication with each other. The executive director of the NFA over there and myself here, along with the team of the Enfield here. We were also in communication with the colleagues in Guinea. And we continuously monitor. What we did on the Enfield side was to immediately get our DIDE, to start activating our port health officers and the district surveillance officers, the zonal surveillance officers, I mean every layer that had to do with disease detection and detective. So we're on the alert. We issue we wrote Dr. Sa, indicating to him that we have heard of this, and we got into discussions with him on what measures we have put in place. Then we had a discussion with him immediately, and together we all put in place the requisite guidepost that will create the situation whereby if there was anyone crossing over that was suspicious, we will be able to arrest the situation. So along the border with Sierra Leone, we had our teams activated, surveillance team activated, and they put health officers. They did the same on their side of the border. Because we were cooperating with each other, we all designed the strategies together. Then we asked if any of the listed person had from their end crossed over. Because these are questions that they would have asked us also. Then they said, no, we have all of them quarantined, isolated, and we are monitoring them. None of them have crossed. But keep watch, because we can never know when that happens. So we were always on the alert, looking at all of those symptoms, looking for all of those symptoms when people cross over. The number one thing, which is fever, then of course, the other symptoms. In the period of time, we have wanted to see what was happening so that we can then institute other measures. For example, invoking the chlorinated hand washing at the border before crossing, which we are going to do, and we will announce that as of this press conference. We will reinstitute the chlorine water at the border, and for counties that are like Cape Mount, Lofa, Bombay, and within this period of time, we will decide, but immediately we want to institute that. So chlorinated water hand wash will be instituted and declared. Hand sanitizing also is a component of that. So coming to the story, that's where we are. We have written, and you will receive all these communications. The letter to Dr. Sa was December 1st, and it says here, report of a suspected case of hemorrhagic fever infection in Sierra Leone. And we were asking what was the status of that before we got into those discussions. In their own publications, they also said suspected case of hemorrhagic fever virus or viral hemorrhagic fever. You can shift those words. Either way, the message will still go. And when we issued our press releases, they also carried viral hemorrhagic fever suspected cases which had samples that were indeterminate. And so we followed the situation in Sierra Leone. We are very glad that the medical establishment here in our country is following the ENFIL very, very, I think, keenly. Unfortunately, in the last couple of hours, 24 to 48 hours, we've gotten lots of calls as to whether in Sierra Leone they heard that there's this happening there, and they're now coming to Liberia. We've heard it from where? From the JFK. That's the release that came from the JFK that says suspected outbreak. That's a different thing when you talk about an outbreak. All of what we have been talking about have just been suspected case, suspected case, suspected case. Not even ENFIL talk about an outbreak of VHF, the viral hemorrhagic fever. And so it started to have people on edge. That is why at this conference we thought we should make that clarification to our people, to the region, and to the world. That number one, there is no outbreak of viral hemorrhagic fever in Sierra Leone. Again, I repeat, there is no outbreak of viral hemorrhagic fever in Sierra Leone. just as I have explained, there was a suspected case. There were lines of contacts that were followed for the 21 days. They are all now being released after those 21 days. But as a good practice, I had spoken with our colleague there. They will still follow them up, to see if anything develops after those 21 days. So we just wanted to make that very clear. We communicated with the JFK authorities and brought this to their attention because in the release we were quoted. I had tried to speak with the authorities there, but they didn't get any call back. So we wanted to make that clear to the Liberian people that there is no outbreak of viral hemorrhagic fever in Sierra Leone, and the NFIL did not report that. So if that can be your headlines, it will be one of the best headlines you will get out of here. No viral hemorrhagic fever in Sierra Leone, reports NFIL on behalf of NFA. You have a very good headline. But one thing we want to really appreciate the JFK about is that quick jump to set up themselves, right? These things are difficult to handle. There's a positive in this, that because of what they were doing, they were following us and follow us very keenly. They followed the National Public Health Institute. They were able to then, get the medical staff informed that, look, we heard about this thing through the National Public Health Institute. Let's get ready because we had our experience before. So they were very proactive. In being proactive, which we very well appreciate, there was just a slight mistake, and this would have caused some havoc. So we really appreciate that proactiveness, and we look forward to talking more. Our lines are open, just as you have always been calling us. We will talk to our JFK colleagues. They can come over here anytime, ask any of our divisions. We are always here to speak to anybody. The Ministry of Justice had called on us one time, and I went there myself and spoke with Councillor Oscar Toy. We had a very beautiful conversation on Mpox. Then I was also called by, at the time, the acting president, Honorable Sylvester Grisby, at the Ministry of State for Presidential Affairs. And he stays late at work. So when I was going there that day, I thought I would miss him. He had written me and wanted us to talk some Mpox and response. He said, my man, you came in. Now we are hearing Mpox in Sano and Rosano. Mpox in Lofa, the president for Lofa. So why are Mpox doing to us? So we joke about it, and we told him, well, you can find it other places too. In Niba is there. So maybe the vice president would have called me also. But we have these sporadic cases of Mpox. We don't have a cluster yet, but what we call cluster, meaning there's so much and then grouping together in regions. So we still have these sporadic cases, and they are coming up, but we keep handling them, and people are giving cure. So, so we are open to discussing with anybody on anything that is happening here. We send the Ministry of Health numerous information, like the epi bulletins, these bulletins that come out every time. The Ministry of Health receives them. The Minister herself receives them. And we text each other. I text every little thing that happens, I text them. Sometimes what I do, I also text the board people, I text them also, so that they can know what's happening to the institution that they are, board members of. So I text the chairman and feed him with this information so that they know real time what's happening here. They don't have to wait for, the bureaucratic quarterly report to hear. By the time we go to that quarterly report, everybody knows what's happening already. So we do that on a regular basis, and we will continue on that. So our lines are really open for anybody, all of you, the press and the public. We receive, in fact, reports of import cases from the public. It will interest you. Some of the cases that we are enumerating here come from the public. The public report that. So it tells us that our communication is going very clear and clean, and people are responding. UNICEF has been doing very, very well in that respect by helping us to do this risk communication awareness in the local vernacular as well. It's been spreading all around the country. So I would like to stop this far and entertain questions, and then we can move on.
Thank you very much. Okay, distinguished colleagues from the media, I think you heard from the DG, that's the purpose of this press conference. There is no evidence, did not say that there's an outbreak of HIV in Sierra Leone. You said it's a suspected case. So we call on you to make that verification and disseminate the information for the benefit of the larger society. Having said that, we will not entertain questions. You call your name, institution, pose a question. Yes, sir.
Good afternoon to all. My name is Figo Mansare. I report for Heritage newspaper.
Nice seeing you.
Okay, then, thank you.
For the first time, face to face.
Yes.
Yes.
From the case, the suspected case.
Yeah.
The history we follow. Even a report from BBC Umaru Fofana.
Yeah.
He mentioned that the fraternity had traveled to Liberia on a medical trip. And so, as a entry trial, which part of of the country that the woman traveled to, or where they conducted the medical exercise upon her return to Sierra Leone?
In our discussion with the director and his team at the National Public Health Agency in Sierra Leone, that did not come up as an information that the suspected case did or may have traveled into Liberia. The only, from the case history, what we learned was this case, this person had traveled to Freetown in order to seek further medical care. Our concern was those who came in contact with this case may have crossed the border. Now, that was our concern. So, that was when the case, the story was developing when Umaru reported. So, the information he gathered is what he reported. If what you're saying is exactly correct. I think I read that also. I read Umaru's report. But then what we were focused on was if any of those contacts travel into Liberia, and that was our concern. Because the case may be already gone, and if it were a confirmed case, full-blown, with no contacts, crossing into Liberia or Guinea, we would have been out for something. But it's good that we just arrested it right there. Those again, they had 291 plus listed contacts, which is very good and huge. And those contacts were isolated, contained, and then followed over the 21-day period of time, and a little over in order to ensure that there was no symptoms, there were no not those classical symptoms, and then they were declared free.
Another person? And then this press conference is the one test press conference. Any other person?
Yeah.
Yes, sir. your name and institution.
I'm Yekezi Sowe from Stone Evidence Theory. Dr. Yan, you talked about research being carried out by the Public Health Institute to determine possibilities of producing vaccines for common illnesses in Liberia. Is there any timeline attached to that?
What we are gathering now are the tools we have, the capability here. The first thing is to gather the tools and the equipment, and then the resources to do that. We have been having goodwill from the travels we've been doing, the conferences we have gone to, from the Africa CDC and many other entities that are very well willing to support in that respect. So in research and development, you don't necessarily give yourself those rigid timelines, because it's not a thing where you have a block here and say, I'm going to build a house and it will take me 3 days to build a house, and you build a house. It goes through a lot of steps. But we have taken the first step, which is very significant, that we want to do this. We have the brains, we are gathering the tools, and then we will start doing that. We hope that within the next 24 to 36 months, we will start having hands-on work being done and some initial results coming up. So we have already been in contact with a few other entities, and that collaboration has started already on diseases like Lassa, which we are faced with here greatly, and then we jump to other diseases once we get to have the science and the technology aspect within our grid.
What? Okay, yeah, Nadia?
Yeah, Lincoln is Dahlia, I represent.
Yeah, go ahead.
Yeah, Lincoln is Dahlia, I represent analyst newspaper. Yes, how do MPhil go about handling this issue where we have people coming from affected countries entering through our border points and also the airports? How do MPhil go about the situation?
We have put health officers that are stationed at the borders, that are stationed at the airport. If we had something, in fact, I will send you some pictures that I took every time I pass through the airport. They are very, very dedicated to the work they do. I stay all the way behind, and I take the pictures of the lines. They are in queue. They check every single passenger. He came from Rwanda recently, and given Rwanda's recent history of Marburg, he was checked thoroughly. So that's how rigid they are. And when I get there, I am a simple passenger. I'm not DG. So yeah. So we on a regular basis we have this border surveillance update, so as to consistently guide ourselves that we're supposed to be doing this every day, every week, things like that. So we have our data here, which is a little buggy that under some conditions can be shared with you.
Okay, last question from my end. So how long does the test take? The test you conduct, how long it take?
The good thing is now it takes us, like the last data I saw, it took us like less than 24 hours to get an mpox test done. So we have almost 20 some samples, and it took us less than 24 hours. We were able to do that and get our results and knew what was positive and what was negative. So there's some improvement thanks to everyone here, and thanks to those questions, because they keep putting pressure on us to do better.
True.
Thank you, guys. My name is Trokon Flamak from Stone Network. You mentioned earlier that you were going to use this medium to officially announce the reactivation of the hand washing and all activities at Europe. But you have not done it, maybe it was an oversight or you want to do it now.
Well, interesting. I think I said that.
Yeah.
That you know. So as of this conference, we are announcing that at the border crossing points, this whole chlorinated hand washing solution will be instituted. Yeah.
Thank you.
You're welcome.
Okay, so cool, thank you. We'd also like to emphasize the National Public Health Institute of Liberia and the GFK have a very cordial relationship.
Certainly.
Very cordial relationship. So please, with the headline,